Well, we're very excited about this because the five of us have been using BioXclude, all of us for different periods of time here. But we always love to compare cases, to compare results, compare techniques. And we're going to try to make this, as interactive as possible. I know that's a little bit hard with five of us, but we'll do the best that we can. We appreciate all of you guys showing up. John and I are going to get started here talking about not only the evolution of collagen membranes in general, barrier membranes, but also, Amnion-Chorion, how we're using Amnion-Chorion. And what you guys have probably noticed quite a bit over the last couple of years is that BioXclude was, of course, the first Amnion-Chorion on the market, and now everybody's trying to copy it. But really, the research, the years of good results with this material, all that research is BioXclude, okay? And so keep that in mind. So every company's trying to kind of catch up, but this is the material that has the research and has the support for it. We'll take a little bit of a poll here. Raise your hand if you've used BioXclude before, or if you've never used BioXclude before. So everybody's hand should be up. Okay, that barely worked. Okay. All right, so, for us, BioXclude is something that we use, throughout our practices, not only for simple cases, but also more complex cases, as you can see. I think there's probably quite a bit of overlap in where we're using this product. But you'll see throughout the presentation, full arch cases. Israel's going to show you some amazing ridge augmentation cases where he's using BioXclude. Me and John are going to sort of lay the the groundwork here.
Really?
Amnion-Chorion, if you guys don't know, it's placental tissue. This material is extremely user-friendly when you know how to use it, but it doesn't behave like a normal collagen membrane. It's not stiff, right? We're not going to be using screws or tacks to place this membrane in, so you do have to get a good feel for the handling of this membrane. And I'll tell you, the way I started using it was I took over working as an associate for one of my very good friends, Dr. Reza Modares. And every case that I had to uncover of his implant would look like this. I'd look in the notes, there was an implant placed, the immediate placement, and I would go to do the uncoveries, and everything was covered by bone, like just completely covered by bone. I'd have to be drilling away using a stud finder to find the implant. And finally, I would go back and look at the chart. In every case, he was using Amnion-Chorion. So that really turned me on to it from the beginning, and that was about 10 years ago. And then we see that, why is this happening? Well, it's acting like a barrier membrane. We all know the purpose as periodontists, why we're using a barrier membrane is to keep soft tissue cells from growing into our bone graft. But this is very unique because no other collagen membrane or no other membrane that we're using actually is a barrier as well as a carrier of growth factors. And that's why this is such a good material. It's got the ability to act like antimicrobial. It's just as it's antibacterial, just like tetracycline is. And that's been documented in the literature. So we have this immunoprivileged allograft tissue that we can use not only to keep soft tissue cells from growing into our bone grafts, but also to supply these growth factors. If any of you guys are familiar with the packaging here, BioXclude, I love the sense of humor. They put the little smiley face on there. And the reason for that is so we know that this membrane can be used either right side up or right side down. It doesn't matter. They're both the same. And so we can do that, and you can see that membrane can go either way. So there's no upside or downside. And then the other thing you'll notice is that it comes in all these different sizes. And the reason for that is because there's so many different ways we can use this material. It's very versatile. So, small sinus tears to lateral windows that we want to cover with our membrane, to large GBRs that you'll see later on, and then everything in between. And really, it's just this versatility, which is why, maybe that's why we needed five of us to kind of go through this, because there's so many different ways of using it. You'll see in this presentation a little of everything, and then we'll sort of dive in deeper to a lot of these procedures as the afternoon goes on. But for small socket grafts like this, to contour grafting, ridge augmentation without an additional membrane, this is going to work very, very well. Cori plates, I know that's all the rage right now, using a block of bone or a plate of bone. Well, it's nice because that plate of bone gives us that great space maintenance. But if you want the security and the addition of growth factors, the Amnion-Chorion goes right over the top and it conforms really, really well. I do this quite a bit. I'll use the Amnion-Chorion in addition to a collagen membrane, okay? In this particular case, which we'll go through in a little bit, I actually wasn't planning on doing it, but if you notice, I over-trimmed my collagen membrane, so my bone graft was sort of squirting out the sides. So to be able to have another membrane that just lies right over the top worked really, really well. I mentioned this already, you know, lateral wall sinus lifts, perforations do occur. As precise as we want to be in using our piezos, it's still very possible to get a perforation. This is a very simple way to repair that, especially for the small perforations. Lateral windows, of course, you know, covering that lateral window with an Amnion-Chorion membrane works really, really well. It conforms beautifully to the defect. And then we are at a perio meeting, so we'll talk a little bit about GTR here. And probably my favorite use for BioXclude, because how many times have you tried to use a collagen membrane and to shape that so it fits interproximally between the teeth? It's very tough. It wants to bunch up on itself. So using it for guided tissue regeneration to me is one of the ultimate uses of BioXclude.
I'll take over here, and this is just a little reminder that I am a periodontist, and I know a lot of what we see out today, whether it's in social media or it's at a conference, a lot of it is really driven by implant therapy. But we want to show some cases to remind ourselves that it's all about trying to save the teeth first. And I don't know if this could be stated any better in which meeting I saw this at, but I find this very much true, honestly, in my private practice as well. But P.D. Miller said that more teeth are lost to titanium than to periodontal disease. And so I want to showcase a case in just conventional periodontal therapy. I don't know about you, but for me, I find GTRs harder to achieve good, predictable results than I do in my GBR procedures. And a lot of time it's because of access. And here we have a narrow infrabony defect. I was very fortunate that I was able to take out the temporary crown to have better access here. Cleaned it out thoroughly as I could. And it's hard to see here on the screen. I promise the resolution's a little bit better on my MacBook, but I got the graft in there and was easily able to drape the BioXclude. And there are a lot of other membranes out there, especially collagen membranes, that handle very well. But no matter how well they handle, it's not easy to fit into tight spaces. And this is what I find as a clear advantage in using BioXclude beyond it being a barrier membrane and also a carrier of growth factors, is being able to have something very easy to use when I am doing surgery. So here's a close-up. I'm all about finding ways to make my life easier. And 5 months out with the temporary crown in place, tissue is not inflamed, got good bone fill, cleared this tooth to get the permanent restoration, probing depths have improved, no bleeding on probing, and we have good bony fill of the infrabony defect with a simple GTR procedure using BioXclude. Now look at this here, and when I look at this, I forgot that I did a flap surgery with GTR here. It almost looks like I did a free gingival graft case here, but many of us probably do not like doing FGGs in the lingual of the anterior mandible. With flap reflection, you can see there are multiple defects here showing the bone loss, and do everything the way you normally would do. Okay, and get that bone graft in place, and you can see the outline on the lower left of where I have the BioXclude, and get that tension-free primary closure and subsequent good healing. And so, of course, as periodontists, we're all biased towards having good keratinized tissue. And what I find very neat about this case is, and I see this quite often with a lot of cases I deal with when I use BioXclude, is not only are we getting a bone fill, but I'm seeing that very positive effect that you have in gaining good, positive keratinized tissue.
So those were two pretty standard GTR procedures. I see, quite a bit of GTR procedures in my own practice. These are two relatively, unique ones where we have some pathology here. So of course, these are teeth that we want to try to save as long as possible. We're going to always biopsy this, which is what we did. This turned out to be a lateral periodontal cyst. But what you can see here, obviously very, very narrow interdental spaces here. We do have a defect in the lingual wall, but we do have the marginal bone intact. Okay, so in this case, obviously, just like John mentioned, we're going to clean this as well as we can. We're going to plane those roots. And one of the things I love about BioXclude is I can put that onto the root surfaces as well. Okay, I can use that. It's got all the growth factors that I want. And what could be easier than adapting this interproximally? There's no trimming of the membrane needed. Okay, me and John talk about this a lot. A lot of times we will take trimmings of the membrane, this is off-label, and mix it with our bone graft because we're adding growth factors. But it doesn't technically need to be trimmed. And so we can have this sitting against the root surfaces of the teeth. This could not adapt any better. And get some nice closure. You can see I had my crestal incision was on the lingual side just to avoid scarring or the risk of things opening. And this is the 2-week post-op. Our sutures are these glycolon sutures that are dyed. So I know this is a 2-week post-op because those sutures haven't lost their dye yet. You can see the buccal view healing very well. And then we have a 1-year post-op. And again, there's great lit here on using the Amnion-Chorion for GTR. Here's another case, very, very similar, but a little different. This one actually turned out to be an odontogenic keratocyst. Very, very high rate of occurrence, but the procedure in itself was the same. We flapped the site open, we curetted very, very well. That's very important to completely remove any epithelial lining. We planed the teeth, but look at the difference in the defect here. So I was really missing, quite a bit of bone there. Again, using the Amnion-Chorion against the root surface is a great way to go, but I also want to maintain a little bit more space here. So in this case, I actually did use a collagen membrane as well, helped to keep a little bit more substructure. You'll see we can use sticky bone, we can use a lot of other things to maintain space. I still tend to like using a collagen membrane in addition to this when I need to build out, outside of the housing. And in this case, I do have some pretty good follow-up. This is immediately post-op. And then we have a view at the 6-month post-op. In this case, I have to see her quite a bit because of the high rate of recurrence of the OKC in this area. And then we have a 2-year post-op with a 2-year radiograph. So she's doing very well. So complete bone fill. We have bone buckle, which is where we lost all of that bone before. And then, of course, interproximally, that bone's maturing. So those are, ways that we're using BioXclude to save teeth. Of course, that's very valuable to us as periodontists. But as John mentioned, a lot of our practices are implant practices where we're doing a lot of socket preservation procedures. We all know, socket preservation, a lot of the time, we can overdo it. We start raising large flaps for no reason. We're actually cutting blood supply to the buccal plate. And so in many cases, what we try to do is to do this as minimally invasive as possible, get our teeth out atraumatically. Well, in this case, I placed an immediate implant. And then I just tuck the BioXclude right over the occlusal. Do I need a membrane there, a barrier function? Not necessarily. And if it's a small socket, I really don't worry that the bone graft's going to come out. But real life, I want to treat my patients, the way I'd want to be treated. I want to have the best chance of having a good outcome. And so I will often do this if I'm not able to immediately load the implant. And I will have the BioXclude basically just sitting over that bone graft without having to raise large flaps to get that BioXclude tucked in. And again, that's the benefit of the handling properties of this material. And so this little video just shows in a case like I just presented, we'll just gently elevate the marginal tissue 1 to 2 millimeters. Very, very, very important is you want to keep that BioXclude dry. Okay, you want to keep the Amnion-Chorion membrane dry until you're ready to use it. And so we'll pack our socket. And then we will use what we like to call the 2-instrument technique. So we're going to use a cotton plier. We're going to take the BioXclude to the socket with our dry plier or tissue pickup, okay? And then we're going to use a second instrument, like a periosteal elevator, either a Boozer or a Pritchard, and we're going to dip that in saline. And we're just going to gently wet the material so that it starts to collapse over that bone graft, right? Again, collagen membranes, you try to do this and it starts to fold over on itself, it's not going to work very well. But for this, it's perfect because any of these areas that have a double layer or they're starting to conform over itself is no problem. And so we don't want to be overly particular here. We don't want to mess with this too much. We just want to get it tucked in just very gently under the marginal flaps. and then we can go ahead and suture this. This is not to get primary closure. We're trying not to put any tension on the margin, but what we don't want to do is pull that membrane out, because once we have it nice and settled over our socket, if we try to put a suture through it and it pulls out, then you got to start over. So we'll just go from internal to external. So we like to call this like a reverse figure 8 suture, and we're just going internal to external, trying not to grab the membrane. And what you end up having when you're tying the suture off is you get the margins of the tissue, the marginal tissue, to almost invert a little bit, and that helps to keep the bone graft and that membrane in place as well. So that works very well for us for these small sockets. And again, this is a very simple case. We're going to move to some more challenging ones, but the key to these types of cases, as John's going to show you, is atraumatic extractions.
And I like what Matt just showed there, and I don't know if he could have said it any better earlier, is that once you know how to use this barrier membrane, because it does handle differently than others, than your typical collagen membrane, it is really easy to use. So that video really well illustrates the proper way to use it. You know, like many things in life, the more you practice it, and it's a small learning curve to it, you'll get better at it, and you'll see that it's a really easy biomaterial to use. And nearly 20 years into my career here, I'm about trying to simplify things. What can I do to make my life easier, work smarter, not harder, when possible? And here I went ahead, and I do this quite often. I use a WAM key to go ahead and remove a restoration if possible, just to keep the area cleaner and make it easier to go ahead and section a tooth. All about divide and conquer, and as much as possible, I always try to do these in a flapless manner and maintain that septal bone in case I want to do an immediate implant. In this case, I chose not to. Grafted with particulate bone, and then laid the BioXclude over the larger molar site. And so like Matt showed in his video, and like what you'll see throughout today's presentation, is the reverse figure 8 suture is the way to go. It really decreases your chance of nicking that membrane and moving it out of place after you spend all that time getting it where you want to have it. The only thing that's different in the molar site than it would be in an anterior site or perhaps a premolar is that I tend to use 2 of these. And this is what I love about this, and this is what I get regularly and predictably with this bioactive Amnion-Chorion membrane, is it's beyond having good quantity of bone. We want to have good quality of bone. And if you look very, very closely here, you're not going to see any residual bone graft particles, indicating that we had really good bone turnover. And you see good bleeding bone, indicating we have vital bone in place. I'm going to shift gears a little bit to what we do a lot of in our private practice. Immediacy is the key. I do not know many people out there who want to have 2 surgeries instead of 1. And so immediate implants is a big part of our practice. Again, take the tooth out in a flapless manner, put the implant in the desired restorable position. I graft the gap, and here it is with a lateral view. And there's that smiley face, known as BioXclude. And gently tuck it in. And like Matt said earlier, the key is knowing how to use it the right way. So you want to use a dry instrument to bring this. Quite often with collagen membranes, what we're doing is we're hydrating it first, and then we're bringing it over. If you do that with this, you're going to learn the hard way that it's not going to be a fun procedure to do. As BioXclude has the epithelial layers removed on the Amnion-Chorion, you know, it's not really site specific, so I always love surgeries when it involves less thinking and just doing. Got a reverse figure 8 suture in there after the membrane's tucked in. Here we are 4 days post-op, and this is what I witness in a lot of my cases, is the advantages you get with this bioactive barrier membrane that is rich in growth factors, that you can get that earlier and faster healing. Sorry. Uneventful healing, 7 weeks out, good soft tissue closure, got the healing abutment in place, and implant crown, maintaining good soft tissue profile, maintaining the keratinized tissue. And here we are. I can't remember how far out this is, but probing depth's great. Bone level looks good. Again, very routine, easy procedure to do.
Yeah, and as John mentioned, obviously our goal is always immediate immediate placement when possible, even immediate loading in a lot of cases. And really the benefit of that is that beautiful soft tissue healing. Be able to maintain the soft tissue architecture is really our goal. But of course, in real life, that's not always possible, as John showed you. And so there was a point in my career where I would place implants in cases like this, didn't feel comfortable necessarily loading the implant, and I would just leave some particulate exposed, and that should do pretty well. That jump cap's usually pretty small. The blood clot stabilizes within the first couple days, and we do pretty well. But now that I know that I have this material that's antibacterial, I will even just put 1 or 2 little sutures here just to hold that in place. Sometimes we'll use an Essex retainer like this as a temporary, but look at that early soft tissue healing. So this is 1 week soft tissue healing, very consistent, like John mentioned. So I mean, that's what we want, really beautiful healing. We know that the soft tissue migrates over that site at about 1 millimeter a day, and so we can do that. Other cases, we do feel more comfortable, we'll place healing abutments, but you can see as soon as we get that tooth out, what happens to that buccal plate? It collapses because we don't have support. So we can go ahead, place our immediate, even place a healing abutment. We have our bone graft material to fill up that defect. And again, sometimes I'll even do almost like an ice cream cone technique with this. So before I put the bone graft in, I'll slide in the Amnion-Chorion in between the buccal plate and the implant, pack it, and then 1 little 6-0 glycolon suture just to hold things in place. You don't want to put tension. You don't want to put any pressure on that buccal plate. But again, that beautiful soft tissue healing at 1 week is what we're looking for. So not only do we get great bone with this, we also get really, really nice soft tissue.
Yes, and not every case is straightforward. This is a patient that has had multiple surgeries, referred from Chapel Hill, and we're going to attempt an immediate implant. You can see there's a lot of scarring. You can see a lot of residual materials left behind, just looking at the gingiva. So like I always emphasize, we try to do this in a flapless manner. Tooth came out very easily, but as I was palpating the facial, I could feel that we had a fenestration lesion, and got my implant in place. And not wanting to disturb the marginal tissue, I went with more of like a semi-lunar approach and raised the flap here and removed as much of that material as I could. And you could see just 2 very small fenestration defects here with a few implant threads exposed and more of a thin buccal plate. I went ahead and got my smiley face out that I want to use as it handles very, very well. And I wanted something that was bioactive as well. So after I grafted the facial and had the custom healing abutment in place, went ahead and grafted the gap, and then sutured this to get closure. And let's see how it looks healing. Oh, I hope I didn't go too fast. I'm sorry. Let me go back. And so healing went very well. 1 week out, I was even able to remove all the sutures, as you see in the top right photo. Was able to maintain a good soft tissue profile and good keratinized tissue and maintain a good level of the marginal tissue. But what is happening underneath here is what I like a lot when you see the CT scan, okay? When you look at the CT scan, obviously we got, at least with the 3D rendering and the CT scan that you see on the left, what you can see is that we not only had the fenestration defect covered, but we had a gain in the facial bone of a few millimeters, I believe, when it was really thin before. And if you remember that GTR case that I showed you earlier, I talked a lot about how BioXclude can have a positive effect on keratinization. It almost looks like a little mini free gingival graft on a little bit more apical there. And so, again, predictability in an area where I feel like there's not as good vascularity because this patient had gone through so many surgeries. There's all that foreign material there, more scar tissue, all the reasons for me to want to incorporate biologics when I treat a case like this.
So, of course, we're always trying to be minimally invasive. John's case clearly was in the aesthetic zone. A lot of times we're taking out premolar teeth, which are also in the aesthetic zone, which is very key. So this is actually my hygienist, and she comes to me, and she's a beautiful girl, big smile, as you can see. So you see this premolar, something's cooking here, and she was very embarrassed to have me look at it. And she was terrified the day that we took these photos, getting ready to do a procedure here. I really, try to make my patients feel very comfortable, and I said, oh, don't worry, immediate implant placement, this will be fine. This is, really run-of-the-mill. So we took a scan here. You can see, You know, a little bit of swelling here, but not really terribly obvious. Obviously, that's where her frenum's attached. But we took the scan, and you can see quite a big blown-out defect. So just like John, you know, I want to do things minimally invasive, but that really means not elevating the marginal tissue, right? Not elevating the papilla if I can avoid it. And so we're always going to extract that tooth from within the socket. And me and John both use this trick quite a bit, so we put both of these in here. I did have the marginal bone intact, but I had that defect apically. So we're going to clean that out through a semi-lunar incision. This is not going to this is going to scar up here, right? But at least it's out of the smile line. And you can see that I was able to actually tuck that BioXclude membrane in. This type of defect that if we get it cleaned out, it's going to heal very well. The defect's within the housing of the bone. And I actually elevated a little tunnel flap here just to be able to tuck that BioXclude in and actually have it over that buccal occlusal line angle as well, which you'll see in the next photo. And then a couple of resorbable glycolon sutures, not trying to get primary closure, trying to be as minimally invasive as possible. You can see she was wearing a S6 retainer as a temporary, much happier now that we got that tooth out, less infection. And then she came back in, we took our CT scan. You can see, again, just very similar to John's case, complete bone fill. But you can see I really packed bone into that buccal occlusal line angle and have it being contained by that BioXclude barrier membrane. And you can see how the site healed. We do have a little scar up here, which I'll take any day of the week. We'll flap this open to place our implant. I don't do things, you know, flapless very often. So we did this with a small little flap, great bone, great bulge of that buccal plate, that buccal occlusal line angle. Was able to place our implant and even immediately load that implant. I just had her come back this week so I could take off the temp and take impressions. And you can see beautiful soft tissue healing. We have that beautiful contour restored. We have from the buccal side, you can see, you know, some papilla now. So we're going to be in really good shape. So again, just trying to do things minimally invasive works really well with this membrane because it does suck down over the defect very, very well. The handling properties of this membrane, obviously, for those small areas work really well, but for these larger defects, there also is a huge advantage to using this type of a material. And you can see here, this case, you guys are all thinking, well, why did he open it? He's telling us to do everything minimally invasive. That's not always possible. In this case, you know, we took out the tooth, we start bone sounding, and we knew from the CT scan, but this case was just an extremely large defect here. Tremendous defect. I'm not going to do a vestibular incision for this type of case. I'm going to flap it open so I can clean this really, really well. But again, the properties of this BioXclude membrane, the handling properties really lend itself for this type of a defect because I can place it over the site dry. I can start wetting the edges of it with a Pritchard or a Boozer dipped in some saline, and it really does suck down nicely. The key here is to make sure you're using a large enough membrane that extends laterally onto the native bone. And again, just showing the healing here, you'll see just the ability of this material to drape. And this is the way we'll do this clinically is we'll place it with the dry instrument to the site, and you see it kind of has memory. It kind of wants to come back up. But the second you dip that second instrument in some saline and start to wet the edges of it, it will suck down, right? So it's important to have enough volume of bone, right? And especially for a defect like this where the defect's kind of within the housing of the bone, this will work really, really well. And you can see, now just because I flap things open doesn't mean I'm going to pull things closed. I like the fact that I'm using a material like this that I can leave exposed. You can see the healing at 1 week where I remove the sutures, and then the 4-month healing. And then when we open this to place the implant, again, complete defect fill, grew bone outside the housing a bit because of the volume of bone that we use to maintain the space. And so this is really a nice way that we can use BioXclude and incorporate it for a lot of the GBR procedures we're doing. If we want to do here's one of my first Corey plates. I was doing a small little case here. And of course, we have the plate here that can help maintain that buccal occlusal line angle, but how easy is it to then just take a material like this that I don't have to cut, that can be touching the adjacent teeth, that can just drape over that site, and that works really, really well. This was 4 months, went back in. You can see nice incorporation of the plate into the buccal wall. Here's something that we're going to see a lot more of later. Dr. Puterman taught me how to do this. In this case, I was using a laminar plate. So this is from Maxius. You can get this through Snow Aces Medical as well. And Israel's going to really break down the use of this material. But basically, I placed my implant immediately. I had some autogenous bone that I mixed with some allograft. And then I used one of these laminar plates to help hold that buccal occlusal line angle. And I used stabilizing sutures here. You can't really see the distal ones because they were 6-0, but there's a distal periosteal biting suture and one on the mesial. And then again, I have good space maintenance here, but I want something to go over that buccal-occlusal line angle that's easy to place, that doesn't have to be screwed or tacked down, because I already have good space maintenance. So this just sucks down right over that site. Here we have our closure. And then, again, you can see beautiful healing. And you're going to see this in a lot more challenging cases later this afternoon when Dr. Puterman goes. But this is really showing you beautiful incorporation. You see that implant, again, covered by bone. So this works really, really well.
Yes, we wish every case could be simple, but quite often we're dealing with the more complex cases here. And this is an elderly gentleman in which you could see an infection on number 9. And so a 96-year-old patient referred for 2 implants and is on Plavix and aspirin, both of which the doctor is not allowing him to go off of. And so one of the first things I think of is, can I somehow refer this either to Matt or one of the 3 other panelists here? If not, and then I want to make sure my AED is certainly working or has batteries that are charged. But in all seriousness, when I get an elder gentleman, or if it's someone that's immunocompromised or a smoker, I want to have something where I could really take advantage of biologics. And that's, again, I emphasize over and over again, what is unique about this barrier membrane here. It's the only one out there that has growth factors, a sustained release of growth factors over an 8 to 12 week period as the membrane is resorbing. And so here it is. 2 teeth easily taken out in a flapless manner. I knew from the CT scan that I was going to raise a flap regardless, but I wanted to keep this atraumatic as possible because I was worried about how much he would ooze and bleed. And in an occlusal view, you could appreciate the defects, but you could appreciate it even more when you look at this on the facial and see that we have complete loss of the buccal. And number 9 is not much better almost with the loss of the whole buccal, aside from having that small isthmus of bone present. And so this surgery, I hate to revisit because it was extremely hard for me to do. And as Matt showed in the prior cases, and if you follow both of us on Instagram or seen us do these webinars or courses, we quite often will stabilize that membrane with sutures. But this patient bled a lot. It was very hard to work on this case. So I did not have time to stabilize a membrane, and there's really no need to do that with BioXclude, in my opinion, and it also depends on the defect or the ridge deficiency that you're dealing with. But it was nice to have something that I could work with really quickly when I was in a very stressful situation. So I didn't even attempt to get primary closure. I wasn't even going to force the issue because I know what properties BioXclude has. It can be left exposed. And you can't blame him being 96 years old coming on the wrong day, and I thought that would be a wonderful photo opportunity. So seeing that this 96-year-old has good healing 4 days out, I mean, not a pretty sight to him, but I appreciate the healing. And 3 weeks out, still looking good. And 6 months out, as the tissue remodels, I'm very happy with this, at least with the way the soft tissue looks. A closer up view of the CT scan shows that we have plenty of bone here. I mean, up to 8 millimeters width on number 8 and 6.87 millimeters on number 9. And here we are at reentry. You know, it's easy to get excited about what may look good on radiograph, but you know, I'm always holding my breath until I see what I have clinically. And at reentry, I don't see many residual bone graft particles. We had good turnover. And this made it for a very simple implant surgery in a case that I was very stressed at the time of the surgery.
Yeah, and as John mentioned, you know, sometimes we don't need stabilizing sutures. We don't even need screws or tacks because maybe we have a defect to graft into. You know, I find for these defects, maybe when they're more outside of the housing, it is beneficial to have some stabilizing sutures. So in this case, I actually planned on using a collagen membrane, and I showed you the pre-op to this case earlier, but you know, sometimes we don't account for that extra bulge of bone graft that we want to place, and I tend to overgraft, especially in the maxillary anterior. I think we have a lot of lip pressure in that area, and things tend to shrink. So I had a collagen membrane that I had over-trimmed. And at that point, I said to myself, well, let me, instead of taking out another collagen membrane and trying to trim it, I just use the large BioXclude and, again, place it over the site dry. I will then go ahead and wet the edges so the edges will suck down over the defect. And again, you can see that just that gross amount of overbuilding that I did here. And then I was able to use stabilizing sutures. Now, you can use stabilizing sutures without the collagen membrane, but because of the handling properties of this, membrane, you can, sort of put too much pressure in certain areas. So the collagen membrane definitely helped here. And we can see the healing at about 4.5 to 5 months. Open this case up. I did have immediate implants in there that were buried. So you have some remnants of the collagen membrane, but very predictable regeneration, this type of a defect. But I think using the growth factors that are inherent to that BioXclude membrane definitely help. And I think you can see that through all of our cases that the bone turnover is very, very good. So it's not to say that we need a collagen membrane here, but I did use one, again, to help grow bone outside the housing. I feel like we did really well here, and I definitely owe that to the fact that we also used that Amnion-Chorion. And again, using some shreds of the Amnion-Chorion mixed with the bone graft is never a bad thing. It adds some growth factors here. Not to say that you can't do this without a collagen membrane, as John will show you.
Yeah, so PRF has become a big part of what I have incorporated in treating my patients. And I know the literature is divided on what benefits there are in terms of the gains or the benefits you get with the bone, but undeniably the handling is much improved when you are using sticky bone. And we got to remember that this BioXclude is handled differently than their typical collagen membrane. And I'm going to show a case to show why I like to use sticky bone at all times when I am doing a ridge augmentation with BioXclude. And so here's a case. I mean, if you looked at the CT scan, there's a mile of bone, but it's not in the right place. So we want to go ahead and augment the facial so that we could have the implant in the future in a desirable restorative position. And like any other ridge aug procedures, we want to follow the past principle that Wong published, get my intramural penetrations to get more bleeding. And this is what I want to highlight here. Typically, if you're going to use a titanium reinforced membrane or if you're going to use a collagen membrane, you will put the membrane in there first. But with BioXclude, typically, almost always, we'll be putting the bone graft in first. So if I'm doing this without sticky bone and I'm putting that bone graft in there, there's saliva, there's blood, and then you get the floating particles, and it just makes it for a much more challenging surgery. So got my BioXclude after the sticky bone is in place, and it drapes very easily. And you want to make sure you get a large enough membrane so that it extends onto the native bone, and it drapes, again, very well. Don't know if I have enough time to go through this whole summary here, as I want to show the outcome of this. But you can see good healing, 6 months out. And what I love is not only just getting at quantity of bone, but when I do an osteotomy at re-entry and it doesn't have any jagged edges, and that really just tells me that we had good bone turnover. You don't have that residual bone graft particles. Easy to place the implant, very straightforward surgery, predictable GBR using BioXclude alone. The shade of that crown is hair off. I don't know if BioXclude had anything to do with that. But what I really like with this is that, I can't remember if this is 1 or 2 years out. I can't remember. But just a cortication. I mean, got some good bone in there from a ridge augmentation procedure. Now, this defect was more involved. And when I have a more involved defect, I want to make sure that I could not only maintain the space well, but also have a longer barrier function. So there's nothing wrong for me. I know Matt and I do this a lot where we will combine membranes together to achieve what we want. And you can see it's almost like a knife edge ridge here. And in the occlusal view here, you'll see that it's, again, maybe 1 millimeter at most in thickness right there. And so I know that this is going to be a little bit more of a complex ridge augmentation procedure. And with all my more complex ridge augmentation procedures in which there's very deficient bone, I'll make sure I always incorporate autogenous because it has the 3 properties that we would like to have in our bone graft. And I also incorporated using 2 tenting screws for space maintenance and also to act as a scaffold. And proceed as I did in a prior surgery. Got my intramural penetrations and got my sticky bone, put a collagen membrane that has a longer barrier effect. And as I had more riding on this procedure, with more hardware in there, I wanted to make sure we were going to have no chance of any exposure, and I really see the positive effects in minimizing my complications when I use biologics such as BioXclude, so you can see it draped over the collagen membrane and get that tension-free primary closure in order to allow for some uneventful healing that we'll see at 1 week, 3 weeks, and here we are at re-entry, removing the hardware. Now, I don't have a crazy amount of bone, but I have just enough that I feel good enough to go ahead and place implant in good quality bone. And that's where we were to begin with.
All right, so I think John and I did a pretty nice job here setting the stage for these 3 amazing clinicians that are going to come up next. But really the key for us is this versatility, being able to use it for anything from, traditional GTR procedures, simple sockets to more advanced socket defects with and without immediate implant placement. And you'll see, throughout the next couple hours, if you guys hang around here, a lot of other uses for this material, which is really unique because of the growth factors that are, inborn into this material, but also the handling properties that really make our lives easier. And I think that's part of it for John and I, is things that are going to make our life more simple. We didn't talk about this much, but as oral surgeons, use very often for nerve repair, and I've seen a lot of lit now coming out on using it for non-surgical periodontal therapy as well. So I think that's a great indication for the future. So I think it's a good place to stop. If there's any questions, we're happy to answer anything, comments or questions anybody has. And thanks again for joining us.
Yeah.
I've used it on a couple of extraction preservations. Now, it'll be stuck down. Preserves as extraction. Once I go to suture.
Those 3 dickheads. Who's the middle dickhead?
You ever get that? Do you think it's a problem?
I don't think it's a problem. I mean, we don't expect any bone graft that's going to be above the crest to really turn into bone, but it tends to act almost like just a scaffold. But the trick, I think, is just making sure that, you're packing bone into that buccal occlusal line angle. That's where we need the bone. And then try that internal to external suturing. Mm-hmm. One of the things that I do quite a bit, which doesn't often show in cases because we don't usually take a photo of this, but I do this even with my collagen membranes, is I'll take some wet gauze and have the patient gently bite on it. That should take care of that problem. You don't want to do that before you suture because with this membrane it'll come right out. But after I get my suture in, I'll put a little bit of compression with wet gauze, and that tends to lower that bone to the occlusal crest. But did you have any issues with the healing in that case? Because typically, like I said, that bone may not turn over, but it'll still act like a scaffold for soft tissue. Yeah.
There's something like that goes against your training, I guess, of using this transparent, it's so thin, and y'all showed a lot of cases where you use it as your sole membrane. And I know you combine it with other membranes too, but I just wonder what your thoughts are about like the resorption of the membrane, the residual of it as compared to some more native or cross-link.
I think
as a mono membrane, one membrane.
I think it depends on the case you're treating. I mean, I know what Matt and I do is we look at all the factors. It could be host factors involved. It could be where we look at the deficiency we're dealing with, and we decide if we're comfortable using it as a sole barrier membrane that's rich in growth factors or combining it with a collagen membrane. I mean, we found it to work well in both ways, but it's certainly, like almost any case you treat in life, I mean, you're not going to do it the same way every single time. It's going to be, patient-driven, host factors, defects. I mean, there's so many, it's really hard to answer that.
I think the shape of the defect is key. The more concave defect within the housing of the bone, we're going to do much better with this membrane than a defect we're trying to grow bone outside of the housing of the bone where we need more, security and stabilization. But what you're saying is not different than the way we thought about this membrane. When I first started using it, I was just putting it in for sockets, right? And I didn't really start using it for ridge-og until I started seeing some of the larger socket defects working. So clearly it does act like, cell exclusivity as a feature of the membrane. But I think also if you're going to be using it without stabilization sutures and you're going to be trying to do ridge augmentation with BioXclude, our flap design's a little bit different. We're not flapping quite as big because we want to kind of use the flap itself to help contain the bone graft a little bit and keep that membrane tucked in. And our treatment sequence is a little bit different, like John mentioned very accurately. A lot of times when I'm using a collagen membrane, I'll put the collagen membrane in first and then pack bone in between the bony defect and the collagen membrane and then fold the membrane over that buccal-occlusal line angle. With this, it's a little bit different. We want to really isolate, the defect and get our bone graft in and then have enough space to be able to tuck the BioXclude in. But for the largest cases, the larger cases, using BioXclude alone, I don't think is great, but that's why we wanted to show that last case using tenting screws. And Israel does a beautiful job of that as well, as you guys all know. There's other things that we can use to maintain space than just a membrane. So tenting screws, in addition to this, is a great combination as well. So great question. That's what we always battle with is material options. We have so many. I often think we have too many. I think you have to find things that work well for you, that work well in your hands, and don't play with materials that don't work well for you. If it doesn't work, it doesn't work. It may work for Kim or it may work for Puterman, and if it doesn't work for you, then that's fine. But that's our goal, is to try to show you how to use it, in these different scenarios. So another hand up here.
There's-
Speaking of the defects of the extraction sites,
Mhm.
I saw that you were tucking the membrane in just kind of like a little bit lightly, but you have a little bit more of an application to distance. Do you find that you're tucking that deeper or?
Yeah, absolutely. That's a great question. So if I have a buccal dehiscence, I'm going to elevate my flap 2 to 3 millimeters past the dehiscence, and then it's a little harder to get the membrane in. What I will actually do is use a 15 by 20, and I'll fold it in half. So now I have a double layer, so it makes it just a little bit stiffer, and then I can tuck that in. And in those cases, I do put the membrane in first before I put the bone graft, because I like to have that membrane confining the bone graft to the socket. I don't want to pack my bone and then try to put the membrane in, because I find that I just get bone on the wrong side of the membrane. But try that double layer technique. It's much easier to tuck that into that space.
Okay, if you have any more questions, we're going to be around this weekend. We're both very active on social media, but we want to give our other panelists time to speak. Thank you so much for coming. Couldn't appreciate it so much.